your feet are cold. They have been cold for a while now, in a way that socks do not quite fix and that a warm room does not fully resolve. Or there is a tingling, a low-level buzzing or numbness that comes and goes, usually in the evenings, usually when you are sitting still. Or a cramping that arrives in the arch or the calf when you walk a certain distance, and that disappears when you stop and rest for a minute, and then returns when you start walking again. You have probably mentioned it to someone, maybe a doctor, maybe a family member, and you have probably been told some version of the same thing. That is just circulation. It is normal when you get older. Try to keep your feet warm. And so you bought another pair of wool socks and you elevated your feet in the evenings and you stopped thinking about it. I want to talk about why you should start thinking about it again. The feet are, in the body, the furthest point from the heart. The arteries that supply them branch from the aorta, travel through the iliac vessels of the pelvis, down the femoral artery of the thigh, past the knee, and branch into smaller and smaller vessels until they reach the capillaries that supply the skin and tissue of the toes. That is a long journey, and it is one of the first journeys to show signs of disruption when the cardiovascular system begins to change. When cardiologists want to assess the health of the coronary arteries, the vessels that supply the heart muscle, they cannot see those arteries directly without imaging, but they can look at the blood vessels of the legs and feet. Because the same processes that narrow and stiffen the arteries of the heart are narrowing and stiffening the arteries of the lower limb simultaneously. The feet are a window. In the symptoms they produce, the coldness, the tingling, the cramping, are the body's earliest readable signal that something is changing in the arterial system. That signal deserves a serious response. Not because every cold foot is a medical emergency, but because consistently cold, tingling, or cramping feet in an adult over 60 are worth evaluating specifically. And the evaluation that matters is not a warm blanket. It is the right question asked of the right doctor, followed by the right test. Before anything else, what I share in this video is educational information only. It is not medical advice. If you are experiencing the symptoms I'm about to describe, particularly pain at rest in the feet or lower legs, color changes in the foot skin, or any wound on the foot that is not healing, please speak with your healthcare provider promptly. These specific presentations require evaluation and should not be waited on. What I want to give you today is the understanding to know which symptoms are early signals worth investigating and which are emergencies that require same-day attention. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60, and the reason I want to make this video is that peripheral arterial disease, the narrowing of the arteries supplying the legs and feet, is one of the most underdiagnosed conditions in adults over 60. Not because it is hard to test for, because the symptoms are easy to dismiss, and the test that confirms it takes about 10 minutes and is available in most primary care offices. The diagnosis that changes everything is sitting on the other side of a question that most people never think to ask. If this is your first time on this channel, subscribe right now. Every week I bring you specific, grounded information about what your body is communicating after 60. You belong here. Let me start with the biology of arterial disease in the lower limb, because understanding it changes how you read every symptom I am about to describe. Arteries are not simply passive tubes. They are living structures. The innermost layer, called the endothelium, is a single-cell lining that regulates blood flow, prevents clotting, produces nitric oxide to allow the vessel to relax and widen, and actively prevents the adhesion of inflammatory cells to the vessel wall. In a healthy arterial system, this endothelial layer maintains its function throughout life. Blood flows freely. Vessels dilate when tissue needs more oxygen. Clotting is suppressed in the absence of injury. But in an arterial system that has been exposed over years to elevated blood glucose, to chronic inflammation from dietary patterns or systemic disease, to elevated LDL cholesterol, to high blood pressure, to cigarette smoke, to any of the factors that damage the endothelial lining, a process called atherosclerosis begins. The damaged endothelium allows LDL cholesterol to penetrate into the vessel wall. Inflammatory cells follow. A plaque forms. And over years, that plaque grows. The lumen of the artery, the open channel through which blood flows, narrows. The vessel wall stiffens. The elasticity that allows the artery to expand in response to demand is reduced. And the lower limb arteries are among the most vulnerable to this process, for a reason that is directly related to their distance from the heart. Blood flow to the feet is already at the far end of the circulatory system, When atherosclerotic narrowing reduces the caliber of the iliac or femoral or popliteal arteries, the first place that reduced flow becomes symptomatic is in the tissue that is furthest from the origin of the reduced supply. The feet and the lower leg. This is peripheral arterial disease. It is not a separate condition from coronary artery disease or carotid artery disease. It is the same process in the same vessels driven by the same risk factors. And the crucial clinical point is this. Adults with peripheral arterial disease have a 2 to 4 times higher risk of heart attack and stroke than adults with similar risk factors who do not have it. Not because the leg disease causes the cardiac event, but because the presence of significant atherosclerosis in the leg arteries tells you that atherosclerosis is likely present in the coronary and carotid arteries as well. A study published in the Journal of the American Medical Association found that fewer than 50% of patients with peripheral arterial disease had been diagnosed with it, and that a significant proportion of those who were undiagnosed had significant cardiovascular risk that was neither identified nor managed as a result. The leg was the window, and nobody had looked through it. The first symptom I want to describe is the one most people have experienced and most people have dismissed. Persistent coldness in the feet, particularly coldness that is asymmetric, meaning one foot noticeably colder than the other, or coldness that does not respond to warming measures the way it reasonably should. The skin of a foot with significantly reduced arterial supply may also have a particular quality, a smooth, shiny appearance reflecting the loss of hair follicle function, as we discussed in a previous video. The seeds at a paler or white tone when the foot is raised above the level of the heart, a dark red or dependent purple color when the foot is lowered, as blood pools in the venous system without adequate arterial inflow to clear it. This color change with position, going from pale when elevated to red when dependent, is called dependent rubor, and it is a sign of significant arterial insufficiency that warrants urgent vascular evaluation. If your feet are consistently cold in one foot more than the other, or if you notice color changes when you raise and lower your feet, or if you can feel that the top of your foot has a diminished pulse compared to what you would expect, these observations need to be taken to a doctor and framed specifically. I am concerned about my arterial circulation in my lower limb. Can we do an ankle brachial index? The ankle brachial index, or ABI, is the test I am referring to. It is non-invasive. It uses blood pressure cuffs and a Doppler probe to compare the blood pressure at the ankle to the blood pressure at the arm. In a healthy circulatory system, the ankle pressure should be equal to or slightly higher than the arm pressure. When the ratio is below 0.9, it indicates significant arterial narrowing in the lower limb. When it is below 0.5, it indicates severe narrowing that may require urgent intervention. This test takes approximately 10 minutes. It is available in most primary care settings, and it is not routinely offered to adults over 60 who present with cold feet and non-specific circulation complaints. Now, ask for it by name. The second symptom is one that many adults with peripheral arterial disease recognize when they hear it described, and that many have been living with for years without a diagnosis. Intermittent claudication, a deep, aching, cramping pain that occurs in the calf, the thigh, or the buttock during walking, that forces the person to stop and that resolves within 2 to 5 minutes of rest before returning when walking resumes. The mechanism is the arterial equivalent of angina. When a partially blocked coronary artery fails to supply the heart muscle with enough oxygen, during physical exertion, the heart muscle cramps and the person feels chest pain. When a partially blocked femoral or iliac artery fails to supply the leg muscles with enough oxygen during walking, the leg muscle cramps and the person feels the calf or thigh ache that forces them to stop. The distance at which claudication occurs, sometimes called the claudication distance, is clinically informative. If a person can walk half a mile comfortably and then begins to cramp, the disease is relatively moderate. If they can only walk 200 meters before the cramping begins, the disease is more significant. And if the progression over months has been from walking without limitation to cramping at shorter and shorter distances, the arterial narrowing is likely progressing and requires evaluation. If this description matches what you have been experiencing and calling leg fatigue or calf tightness from walking, please bring that description to your doctor, framed in terms of the distance at which it occurs, the specific location of the discomfort, and the fact that it resolves with rest. That clinical picture is the indication for an ankle brachial index, and the ABI result tells you whether you need to be seen by a vascular specialist. Type in the comments right now if you have experienced leg cramping or aching during walking that forces you to stop and rest, and have attributed it to age or arthritis, rather than having it specifically evaluated. Because that symptom has a name, and that name changes the cardiovascular risk conversation significantly. And share this video right now with one person in your life over 60 who complains about their legs giving out when they walk. You may be giving them a diagnosis they have been walking around with for years. I want to tell you about Frank, 74 years old, retired postal worker from Denver, Colorado. He came to me not because of his legs specifically, but because of fatigue. He was finding that he could no longer do the things he used to do with physical effort, without stopping more than before. When I asked him specifically about his legs, he described something he had been living with for about 2 years. He could walk to the end of his street, about 300 meters before his right calf began to ache, deeply enough that he needed to sit down. After 2 or 3 minutes, it resolved. He had assumed it was his knee, or his age, or a result of decades of walking routes on hard pavement. He had told his previous doctor about it once. He had been told to stretch his calves. Frank had also noticed his right foot was consistently colder than his left. He wore an extra sock on the right foot in the winter. He had never mentioned this. An ankle brachial index showed an ABI of 0.62 on the right leg, indicating moderate to significant peripheral arterial disease. An ultrasound of the right femoral artery showed a high-grade stenosis, a narrowing of more than 70% of the vessel lumen. His right leg had been receiving less than a third of the blood flow it should have been receiving for at least 2 years. Not just his leg. It must be him, his cardiovascular system. His cardiac risk assessment was recalculated on the basis of the PAD diagnosis. He was referred to both a vascular specialist and a cardiologist. A coronary CTA performed as part of the cardiac workup showed significant coronary artery disease that had been entirely asymptomatic. 2 discoveries from one specific question about leg cramping while walking. Frank told me, "I thought it was just my age catching up with me." I told him, "It was not your age. It was your arteries telling you something in the only language they had for 2 years, while everyone who examined you was looking somewhere else." Beyond peripheral arterial disease, there is a second and equally important reason that the feet develop the specific sensations I described at the start of this video: diabetic peripheral neuropathy and the vascular changes of chronic elevated blood sugar. We have discussed this in previous videos on this channel. But in the context of blood flow specifically, the distinction between arterial insufficiency and diabetic neuropathy is worth understanding clearly, because they can coexist and they require different evaluations. Diabetic peripheral neuropathy produces sensations that are often described as tingling, burning, or electric, particularly in the soles and the toes, and most prominently in the evening and at night. This is small fiber nerve damage, driven by the toxic effect of chronically elevated glucose on the Schwann cells that maintain the myelin sheath around nerve fibers. The sensation is neurological in origin. The nerve is sending distorted signals. It is not primarily a blood flow problem, though elevated blood sugar also damages the small vessels supplying the nerves, so the 2 processes overlap. Peripheral arterial disease tends to produce coldness, pallor, cramping with activity, and pain at rest in advanced stages. The sensation is circulatory in origin. The tissue is not receiving enough oxygen. The distinction matters because the test required is different. Neuropathy is assessed with nerve conduction studies and skin punch biopsy. Arterial insufficiency is assessed with the ankle brachial index and arterial duplex ultrasound. And the management of each is different as well. What they share is a common upstream driver: elevated blood glucose. High blood sugar damages both the nerves and the small blood vessels simultaneously, which means that adults with prediabetes or undiagnosed type 2 diabetes may develop both neuropathic and vascular symptoms in the feet before any formal metabolic diagnosis has been made. If you have tingling or burning in both feet that is symmetric, worse at night and accompanied by coldness, you may be experiencing both processes operating simultaneously, and neither one will be addressed by a warm pair of socks. The tests to request are an HbA1c to assess 3-month average blood glucose, an ankle brachial index to assess arterial flow to the lower limb, and a discussion with your doctor about whether a formal neuropathy assessment is warranted based on the symptom pattern. These three together give you a meaningful baseline picture of what is happening in the feet and why. If you have subscribed to this channel, I am genuinely grateful for your presence here. And if you have not yet, tap that button now and ring the bell. Every week I come here with exactly this kind of specific, actionable information, because vague reassurance is not what you need after 60. Let me talk about the role of blood thickness and hydration, because it is a variable that most people underestimate in the context of lower limb circulation. Blood is not a simple liquid. It is a suspension of cells, proteins, and lipids in plasma, the watery base fluid. The proportion of red blood cells to plasma, called the hematocrit, affects how thick the blood is and how easily it flows through smaller vessels. And the concentration of clotting proteins in the blood, elevated by dehydration, by certain medications, by inflammatory states, and by some cancers, affects how readily the blood clots when flow slows. In an artery that is already partially narrowed by atherosclerotic plaque, blood viscosity becomes critically important. Thick blood moves more slowly through a narrowed lumen. The flow in the region just behind the plaque, where turbulence creates zones of slower moving blood, is where clots can form. And a clot forming in a partially narrowed artery of the lower limb, whether in the iliac, the femoral, or the popliteal, can suddenly convert a moderate circulatory problem into a complete occlusion. This is called acute limb ischemia, and it is a vascular emergency. The leg that has been receiving reduced flow through a narrowed artery suddenly receives no flow at all. The symptoms are abrupt and dramatic: sudden severe pain in the leg, coldness and pallor that appear within minutes, loss of sensation, and eventually loss of movement if the occlusion is not reversed. This requires emergency vascular intervention. The window for limb salvage after complete arterial occlusion is measured in hours. Understanding this does not mean living in fear of it. It means understanding that the chronic management of arterial disease matters, that blood viscosity is a modifiable variable, and that adequate hydration, appropriate antiplatelet therapy, where indicated by a physician, and avoidance of prolonged inactivity are all relevant to reducing the risk that a stable chronic narrowing becomes an acute event. Dehydration specifically thickens the blood. The plasma volume decreases, the hematocrit rises, the concentration of clotting factors increases. And in an artery already narrowed by plaque, thicker blood moving more slowly through a reduced lumen is exactly the condition that predisposes to clot formation. This is why adequate hydration, 6 to 8 cups of water through the day, is not just advice about kidneys and digestion. It is vascular advice. It is relevant to every adult over 60 with any degree of arterial disease, diagnosed or not. Prolonged inactivity has the same effect through a different mechanism. The calf muscle pump, the mechanism by which leg muscle contractions drive venous blood upward against gravity, also creates the suction effect that draws arterial blood into the lower leg. When the calf pump is inactive for extended periods, blood pools in the lower leg veins, venous pressure rises, and the pressure gradient driving arterial inflow from the feet decreases. And circulation slows. And slow circulation in an already narrowed artery increases clot risk. This is why movement matters so directly in peripheral arterial disease, not as a general wellness recommendation, but as a specific vascular intervention. Walking, even in the presence of claudication, produces adaptations in the arterial system. Collateral vessels, small bypassing channels develop around points of narrowing in response to the repeated demand of exercise. Clinical guidelines for peripheral arterial disease specifically recommend supervised walking programs as a first-line treatment, not because the exercise is generally good, but because it produces measurable changes in the vascular anatomy of the lower limb over weeks and months. Let me now be direct about the specific symptoms that require urgent or emergency evaluation, because the line between a symptom worth monitoring and a symptom worth acting on today matters enormously in peripheral arterial disease. Symptoms that require same-day evaluation, meaning contact your doctor or go to an urgent care today. A new development of pain in the foot or lower leg that is present at rest, not only during walking. Resting pain in peripheral arterial disease is called critical limb ischemia, and it indicates that the arterial supply is insufficient even for the baseline metabolic demands of resting tissue. This is a significant escalation from claudication and requires urgent vascular specialist involvement. Also, a wound or sore on the foot that has been present for more than 2 weeks without clear improvement. In a limb with compromised circulation, wounds that do not heal are at serious risk of becoming infected and not responding to standard treatment. Also, any significant increase in the severity of existing symptoms over a matter of days. Symptoms that require emergency evaluation, meaning call emergency services or go directly to an emergency department right now. Sudden severe pain in a leg that was previously manageable. Sudden onset of coldness, pallor, or bluish discoloration of the leg or foot that appears over minutes. Loss of sensation or movement in the foot or lower leg. A leg that becomes very white or very mottled and cold, without an obvious environmental explanation. These are the symptoms of acute limb ischemia, the sudden arterial occlusion I described. This is a vascular emergency with a time window of hours. Do not wait. Do not try additional home remedies. Emergency evaluation immediately. And I want to say something directly to the adults watching this who tend to minimize their symptoms, who would rather not bother anyone, who would rather wait to see how things develop. The arterial system of the lower limb has a limited capacity to compensate for progressive narrowing. The symptoms that seem mild today can progress to critical ischemia. The clot that forms on an unstable plaque does not give warning. The time to evaluate the circulatory health of the lower limb is not after a crisis. It is when the first cold foot and the first claudication distance give you the opportunity to catch the process early, when the options are broadest and the outcomes are best. Here's the framework for the conversation to have with your doctor. Describe any lower limb symptoms specifically. Temperature differences between the 2 feet. Any cramping or aching in the calf, thigh, or buttock with walking, including the approximate distance at which it begins, where exactly it occurs, and how quickly it resolves with rest. Any tingling or burning in the feet, particularly whether it is symmetric or favors one side, and whether it is worse at rest or with activity. Any skin color changes in the feet, particularly pallor or bluish discoloration that is new. Any wounds on the feet that are slow to heal. Then ask specifically for an ankle brachial index if your symptoms or risk factors warrant it. Your symptoms warranted if you have any of the following: claudication during walking, persistent cold or color asymmetry in the feet, any diagnosis of diabetes or prediabetes, a history of smoking, a diagnosis of high blood pressure or high cholesterol, a previous cardiac event or stroke, or simply being over 65 with any lower limb symptoms that have not been specifically investigated. Ask for an HbA1c if your blood glucose has not been assessed in the past year. Ask about an antiplatelet medication if you have confirmed peripheral arterial disease and are not already on one. And ask whether referral to a vascular specialist is appropriate for your findings. The habits that most directly support arterial health in the lower limb are the following: walking regularly. Even in the presence of claudication, walking to your comfortable distance and then resting and walking again, repeated across a session, produces the vascular adaptations that gradually extend that distance. Consistent hydration. Adequate fluid intake through the day to maintain blood viscosity and support arterial flow. Blood pressure management, because hypertension accelerates atherosclerosis in the lower limb arteries, just as it does in the coronary arteries. Blood sugar management, because elevated glucose drives both the small vessel disease of neuropathy and the large vessel disease of atherosclerosis simultaneously. And if you smoke, the single most important vascular intervention available to you is stopping, because tobacco use is the most powerful accelerant of peripheral arterial disease in existence, producing vasoconstriction, endothelial damage, and platelet activation that dramatically worsen the condition at every stage. 4 things I want you to carry away from this video. First, cold feet, tingling, and cramping during walking are not simply features of an aging body. They are readable signals from the arterial system that deserve evaluation, with the right test, which is the ankle brachial index, and that may reveal cardiovascular risk that changes the entire management picture. Second, peripheral arterial disease and coronary artery disease are manifestations of the same underlying atherosclerotic process. A significant finding in the lower limb arteries is a strong predictor of cardiovascular events. The diagnosis of PAD is not a leg problem. It is a cardiovascular problem that happens to present in the leg first. Third, the difference between chronic manageable symptoms and an acute vascular emergency can be sudden and dramatic. Knowing the specific features of acute limb ischemia, sudden severe pain, sudden pallor and cold, sudden loss of sensation, is the knowledge that turns a potentially catastrophic event into a salvageable one, because the decision to call emergency services immediately, rather than waiting, is the decision that preserves the limb. Fourth, the evaluation is simple and available. An ankle brachial index takes 10 minutes. and HbA1c takes a blood draw. Neither requires a specialist referral in the first instance. Both can be initiated by your primary care physician. What they require is that you ask for them specifically, with the words I have given you today, rather than accepting a general reassurance about circulation and aging. Your feet have been bearing your weight across every decade of your life. They deserve your attention. Not anxious attention. Specific attention. The kind of attention that leads to a 10-minute test and a result that tells you whether the circulatory health of your lower limb is something to monitor, something to manage, or something to act on urgently. You are not too old to benefit from that evaluation. The earlier the peripheral arterial disease process is identified, the more options exist for managing it and for protecting the cardiac and cerebrovascular health that travels with it. Share this video with someone who has been told their cold feet are just aging. And subscribe to this channel, because every single week I come here with one purpose: to give you the specific information that helps you recognize what your body is telling you, and to act on it before the window closes. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.